Yes, ma'am.
Good evening, young Turk. First of all, I must wish you happy World IVF Day and happy World Embryologist Day. So this young Turk, we are doing every Friday, every second and fourth Friday, twice in a month. Vision of our president and secretary behind this is to empower, nurture, and evolve the young Turk, especially presentations and publications and all. So today we have expert with us, Dr. Kuldeep Jain sir and Dr. Sarabji. And Dr. Ankita is speaking on very pertinent topic about predictor of success after IVF. So let's start the session. So Ankita, please share the slide.
Is it visible?
Yeah. So welcome, Dr. Kuldeep Jain sir. We are having with us Dr. Kuldeep Jain. He is the director, KG IVF and Laparoscopic Center, founder, secretary, and past president, Indian Fertility Society, chairperson, International Exchange Committee, Indian Fertility Society, editor-in-chief, Fertility Science and Research, instrumental in conceiving and introducing multiple projects in IFS like ASHRAE preparatory course, educational fellowship program, affiliation to MIT University, IOI workshop, newsletter and journal, FSR. Brought ASHRAE campus course, IFFS World Congress and Fusion. Recently, we are going to have joint conference of ASHRAE IFS SR to India. Chairperson Endometriosis Committee, past chairperson Endometriosis Committee, now the chairperson of the Fusion 24 at Jaipur. Board of Direction member Scientific Committee IFFS, chairperson Infertility Committee AOGD. Delivered more than 400 invited lectures and orations, recipient of Lifetime Achievement Award IFS, Appreciation Award from IFS, IMA, DMA, and FOXY. So welcome, sir.
Thank you.
Right, Ankita. So you can, we are having the Fusion conference, which sir is going to be the chair of the session. You can tell us.
Yeah, actually, this is one conference which is coming in your way. This is first physical conference with ASHRAE coming to India, and this is a golden opportunity to all youngsters to present their research work in this conference, because this will provide an opportunity to present yourself on an international platform. You need not to go to ASHRAE. This is coming to India. So all those who are really interested in research work and publishing their articles, even we are having the human reproduction editorial team coming up, and we will be having one FSR workshop in this conference. So please register and submit your abstract. Abstract date is, I think, 15th August. So please register and block your date and send your abstract. Thank you.
Next slide, Ankita. So now my pleasure to invite Dr. Sarabji, our next expert. He's consultant reproductive medicine and OBG at Sarab Health and IVF Center, Jalandhar, medical director, Dove ART Bank, Jalandhar, past immediate secretary IFS Punjab chapter, convener of the SIG Andrology, treasurer of the IFS Punjab chapter, organizing member Fertivision 2020, organizing chairperson Fertility Concept, organizing Fertility Concept Annual Conference IFS Punjab chapter, more than 100 lectures and discussions, 9 chapters, publication and research article, best paper in Fertivision 2022. So welcome, Dr. Sarab Singh.
Thank you, ma'am. Thank you, ma'am.
So today we are having with us Dr. Ankita Srivastava. She is awarded Safong Young Gynecologic Award 23. And at present, she is at Amrita Institute of Medical Science, Kochi. So yes, Ankita, now the floor is yours. So we are having very important topic, predictors of success after IVF. Yes, Ankita.
Thank you, ma'am, for the kind introduction. Today, we're going to talk about the article published in Fertility Sterility in 2024, Predictors of Success After IVF. So the last few decades have witnessed a rise in global uptake of IVF and various predictor models have come up. So this review is identifying about 11 predictors. Now we're going to name the predictors and look into each of them individually according to the various studies reviewed. They've included age, duration of infertility, ethnicity, BMI, antral follicular count, previous pregnancy history, cause of infertility, sperm parameters, numbers of oocytes collected, morphology of transferred embryos, and the day of embryo transfer. So an earlier systematic review was done by Van Loder-Sloot. He had enlisted few important parameters that he had included that were female age, duration of infertility, number of oocytes, and basal FSH levels. As time progressed, more and more potentially important factors with their complex relationships with the outcome have been studied. So a more recent systematic review was by Ratna et al., which was published in Human Reproduction in 2022. It has undertaken a detailed examination of the quality of IVF treatment prediction models. So the aim of this review was to review the role of predictive factors in estimating the chances of success after IVF treatment. The initial search included about 1,810 articles, but a lot of records were removed. Either they were non-human studies or there were duplicate records. And overall, about 43 studies have been included in this review. So let us go through the predictors one by one. So the pre-treatment factors include the age. The female partner's age is a key factor influencing the likelihood of conception after IVF because of its impact on the quality as well as the quantity of the oocyte pool. So about 43 studies that were included, nearly all had age as an important criteria. 42 out of these 43 studies have included age as one of the predictors. And some studies have taken age as continuous variables. Some studies have taken it into groups. So only 2 studies have similar age bands, like 20 to 24, 25 to 29, going up to 40 to 44. So this important study, which was conducted by Templeton et al., which categorizes the relationship between age and live birth using fractional polynomials, they have quoted highest live birth rate between the ages of 25 to 30, and a sharp decline was seen after 35 years. Similar results were seen in studies by Hughes et al. As well as Jones et al., where they are saying highest live birth is below 30, and after 30 to 35, there is a sharp decline. So that is why age is such an important factor. Another study was done by Liu et al., and they have taken the light gradient boosting machine model. Predicting factors were divided into 2, one before the first cycle and those after the first cycle. And they are defined on the basis of their feature importance. Feature selection has been performed by machine learning factors like unsupervised or supervised methods. And out of all these factors, maternal age was found to be the most important predictor, both before the first IVF as well as in subsequent cycles. So here we can see before the first cycle also maternal age has a huge impact, and even after the first cycle, the maternal age has a huge impact. So the various models that have been studied, like extreme gradient boosting, random forest approaches, all these have found that female age is the most influential factor. Also, there was a Shapley additive explanations value, wherein the higher you go, particularly in the older age groups, they were linked to less favorable IVF treatment outcomes. So this was about the age. Now, as we come to the cause of infertility, about these 43 studies, 21 studies have reported on the association between the cause of infertility and IVF treatment success rates. And they included tubal factors, endometriosis, ovulatory dysfunction, and unexplained infertility. So what they have concluded after Templeton, after 37,000 treatment cycles, said that there was no significant difference in live birth rate where there were different causes of infertility. However, unexplained infertility could expect a higher live birth rate when they compared them to tubal disease. Similarly, Bhattacharya also, after studying about 1,21,000 cycles, said that unexplained infertility was associated with a higher live birth rate than if there were known factors like tubal disease or male factor, or a combination of these. Similarly, Luke et al. Also said that unexplained infertility had a better outcome, and diminished ovarian reserve along with male factor and tubal factor had lesser outcome in terms of live birth rate. Now, McLaren said that positive association was there between live birth and anovulatory and unexplained infertility, whereas negative association with tubal factor and male factor infertility. So all these studies are pointing in favor of the unexplained infertility when compared to tubal factor or male factor infertility when assessing the live birth rate. Now, coming to the duration of infertility, 19 out of these 43 studies have quoted duration as an important factor. And most of these saying that about 1 to 3 years of infertility will have a highest likelihood of live birth. And when it proceeds to 6 to 7 years, there will be a sharp decline in the live birth. McLernon again goes on to say that chances of live birth declined linearly with each year. So the high dimensional data sets give importance to the individual parameter for optimizing the performance. And a random forest model was done by Mehrjerd, which says that the importance of duration was as high that 3% contribution was there to the overall predictive model of the outcome. So the clinical pregnancy rate peaked between 0 and 5 years of infertility, and after that fell sharply beyond 5 years. So what they're trying to say is that once the pregnancy rate is to be assessed, you have to assess how much is the duration of infertility. Highest live birth rates could be expected at 1 year, followed by a gradual fall up to 5 years, plateauing between 5 and 9 years, and subsequently thereafter they are declining. Now coming to previous pregnancy history, whether there's a primary infertility or a secondary infertility. Previous pregnancy history has been included in 17 of the reviewed models. And they are saying that if there was a previous pregnancy, there is a higher rate of live birth rate. But interesting, what they are saying is that this live birth rate is more pronounced when the female had a history of prior IVF treatment-induced pregnancies. This is what Templeton is saying. And similarly, this is what Nelson and Lawler are saying, that live birth increases if there was a previous pregnancy, no matter what the pregnancy ended as a live birth or a miscarriage. And more so, if the previous pregnancy was induced by an IVF treatment, the chances of live birth rate in subsequent pregnancies are increasing. Body mass index, it is noted to be a predictor of IVF treatment in about 14 out of 43 models. Now, there was a study by Zhu et al. What it said was that it had a 3% decline in infertility with each unit increase in BMI beyond 19.5. So for BMI less than 19.5, risk of infertility was higher by 33%. And also after 19.5 with each unit, there was a 3% decline. Similarly, Luke et al. Said that the highest success rate was between the BMI of 18.5 to 24.5 for 9. And if they're going away from this parameter, then the success rate is decreasing. So for BMI, it is reduced. The success rate is reducing as the BMI goes from 25 to 35. Ovarian reserve, AFC and AMH values. Not all studies have included both AFC and AMH as a predictor. So with age, there is a gradual reduction in oocyte numbers, primarily attributed to atresia, with a sharp decline by the age of 35 years. Measuring ovarian reserve includes either AFC or AMH, and some studies have included both. So there are 7 prediction studies, including just AMH, and 6 included just AFC. Only 2 studies out of these have included both AMH and AFC in their final model. So what is the outcome of AMH on IVF success? Gomez et al. Concluded that extremely low AMH values do not rule out the possibility of successful treatment, and the decision to forego IVF treatment should not be solely based on the AMH level. There are other factors that may supersede it as well, like age, cause of infertility, and duration. And about the antral follicular count, Silva et al. Noted that there was a positive correlation between the antral follicular count with retrieved oocytes and negatively with age. So what he did was he divided the patients into 3 groups depending on the follicular numbers. Up to 10 follicles, 11 to 22 follicles, and more than 23 follicles. He found no significant association between groups with varying follicular count and patients with positive pregnancy rates. But when he did a multivariate analysis, what he found was there was a cutoff of 27 antral follicles, beyond which the likelihood of successful gestation seemed to plateau. Similarly, Metello has divided on the age groups less than 35 years and more than 39 years, divided AMH on the basis of AMH and AFC. And he has found that live birth rate was higher in the patients who had higher AMH and higher AFC, especially in the ones with male factor or ovulatory infertility. He had better results. A machine learning model by Gouverneur assessed the featured weights of the antral follicular count, and he found that it has a small positive impact on the predicted outcome. The overall weight was 0.54. So it had a positive impact on the predictive outcome. So this was about antral follicular count and AMH. Coming to ethnicity, the data from Human Fertilization and Embryology Authority has quoted that live birth rates in Black women aged between 30 to 34 years was 23% lower than mixed race or white patients. Similarly, the tubal problems he found in Black patients were higher, as 31% compared to 18% in the overall IVF treated population. Also, he quoted that Black patients started IVF treatment 2 years later, about 36.4 years compared to the other ethnic groups. So what they're trying to say is that there are only 2 IVF models that have included ethnicity as an important predictor. One was by Dillon et al. In 2016, published in Human Reproduction, and the other one was published in 2019. Both are saying that there are lower chances of success in Black and Asian women compared with white women. Coming to lab or post-treatment parameters. The embryo parameters were included in approximately half of the studies that were included. They included morphologically assessed quality, day of transfer, number of embryos transferred, and whether it was a fresh or a frozen embryo that was used. And they have used so many approaches like dynamic time-lapse imaging, etc. So the widely used Gardner blastocyst grading system focuses on blastocyst expansion, trophoectoderm, and inner cell mass. So now they evaluated the embryo quality and linked it with implantation, clinical pregnancy rate, and live birth rate. So among the 21 studies, 11 specifically examined embryo quality using morphokinetic parameters. Because especially in cases where pre-implantation genetic testing is not conducted, embryos are commonly selected for transfer on the basis of their quality. A Hunold model was there in 2002, which assessed embryo quality using developmental stage scores and morphological scores. So what they had done was they had done single embryo transfer, and 2 embryos were transferred in patients that needed it. And they have assessed what was the important parameter that was affecting the live birth rate in the 2 embryo transfers that they have done. They categorized that the developmental stage of the best one and the second best embryos, along with their morphological gradient, was done. The categorization was done, and the best predictors were the developmental stage of the second best embryo and the morphological score of the best embryo transferred. So these similar findings were also observed in other studies, like one with Ottosen and Linsen in 2007. And they have told that developmental stage of the second best embryo and morphological score of the best embryo transferred correlated best with the live birth rate. What about the number of oocytes collected? Various studies have been done about the optimal number of oocytes collected. Gast et al. Said that the improved pregnancy rate was seen up to 13. And when they got higher number of oocytes, it negatively affected their pregnancy rate. Subsequent, another study was done about 4 lakh IVF treatment cycles, and they said that median count of retrieved oocytes was 9 and showed a positive correlation between the probability of live birth and oocyte number. The chance of live birth per IVF cycle was increasing up to 15 eggs. It was following a plateau between 15 to 20 eggs, and subsequently it was declining. Another study was done by Smelzer in 2019, where they said that the odds of clinical pregnancy and live birth increased by 8% with every additional fertilized oocyte up to 9, and then declined by 8% for every additional fertilized oocyte beyond that. But there were some drawbacks of this study. They failed to mention the risk of OHSS. They did not include the cumulative live birth rate, and it was based on the treatment cycles rather than the woman. So the woman was included potentially more than once. So to circumvent that, another study was done, which was a large multi-centric study across 15 European tertiary hospitals and included about 15,000 women by polysource. Each patient was included only once. Here, they found that the probability of live birth increased up to 7 oocytes and remained relatively unchanged up to 20 oocytes. Beyond that, there was a significant decline. When they checked the cumulative live birth rates, they said that it increased steadily with an increase in the number of oocytes, reaching 70% when 25 oocytes were retrieved. So this was about the number of oocytes. Coming to the semen parameters, out of the 43 studies analyzed, 10 included the semen parameters. Villani et al. In 2022 highlighted the impact of sperm motility and morphology on live births. So within the IVF treatment, the importance of progressive motility, motility after capacitation on fertilization rates were observed with subsequent implications on live birth rate. So what they found was that motility predicted fertilization, pregnancy rate, and live birth rate in IVF treatment, whereas sperm morphology was associated with clinical pregnancy and live birth rate in ICSI. They had also done a review by Bolle et al., where they had conducted a study based on sperms obtained with testicular sperm extraction for ICSI. And they found that total motile sperm count of more than 10 million was predictive of success in IVF and ICSI treatments. Another systematic review and meta-analysis was done in 2022, which was based on 17 studies. They failed to form an association between sperm morphology, male age, and pregnancy rates. Meta-regression revealed a negative association between sperm concentration and clinical pregnancy rate, but there was a limitation of the study because there was significant heterogeneity among the included studies. Day of embryo transfer has an important implication. There are only 2 prediction models quoting this. Gartner et al. In 1998 demonstrated higher success with blastocyst transfer compared with cleavage stage embryos. So there was a shift in embryological practice towards blastocyst stage transfer. But recently, a controlled randomized trial in 2000, as well as one published in 2023, have quoted that what compares the success rate is basically cleavage stage and blastocyst stage embryos. So only thing is that cleavage stage embryos will require more numbers to achieve similar live birth rate, but there was comparable success rate whether we are transferring cleavage stage and blastocyst stage embryos. So when we come to the discussion, female age has been included in about 98% of the IVF treatment prediction models, and it has the highest impact on the chance of clinical pregnancy or live. Other key predictors that have been included, they had variable levels of influence on success rate. The strengths of this study is that it is the second study to investigate the role of individual predictors in the success of IVF treatment. It has included a wide range of predictors and wide range of models, the earlier one as well as the more recent ones. So all studies have been included. So there are 2 types of models that can predict. Regression models that will quantify the relationship between a predictor and the outcome by providing coefficients that indicate the strength and direction of the association. Another one, random forest or gradient boosting model, will provide metrics on the basis of the contributions of individual factors. This study has reported both parameters to comment on the importance of the common predictors of IVF treatment success. So that is a great strength. When we talk about limitations, this was unable to aggregate data on predictors' weights because they were expressed in different forms across different studies. Like supposing age, in some studies, it was taken as a continuous variable. In some studies, it was taken as groups. So it was not uniformly included. Another important limitation is that it has a relatively narrow scope. That is, the role of individual predictors in IVF treatment did not seek to assess the performance of IVF models and their clinical applicability in routine use. So that has to be assessed. What are the clinical implications that we need to assess? Given that female age is the most important predictor, we have to tell patients about our age-related risks and empower them to take timely, informed decisions. Duration of infertility has a moderate effect on IVF treatment outcomes. This underlines the importance of optimal timing for IVF treatment while avoiding the risks of overtreatment. Black women or Asian ethnicity should be offered treatment earlier than their white counterparts. And we have to encourage women to attain a healthy BMI, not only to avoid pregnancy complications, but also to enhance success rate with IVF intervention. Higher number of retrieved oocytes improve cumulative live birth rate, but this comes with an increased risk of OHSS and multiple pregnancy. Sperm motility and concentrations have a positive association with IVF treatment success rates, as do high quality embryos, whereas the day of embryo transfer does not significantly influence the outcome of treatment. This will help us to individualize the treatment and optimize the treatment success. But do we really need all the predictors for estimating success? The 11 predictors have been considered, but do we really need them all? Because this raises a question about the individual value of each of them. Meta-analysis, which could provide a way of ranking them, is challenging because of the different ways in which these variables have been measured and reported. Age is a key predictor. It has a direct negative impact on ovarian reserve, exemplified by diminished levels of AMH and AFC, especially beyond 35 years. So now the ovarian reserve tests, only 2 of the ovarian reserve tests, they have included both AMH and AFC. A study by Metello was done, which highlighted a significant association with live birth outcomes. The combined utilization of these markers did not markedly enhance the live birth rate. AMH has limited value in predicting 1-year cumulative live birth and offer minimal additional benefit beyond age-based prognosis. In contrast, there were certain models which were developed by McLaren and externally validated by Liddeckers that did not include AMH values at all. These models propose that the integration of ovarian reserve measures such as AMH and AFC provides marginal improvements in predictive capacity despite the additional costs and clinical burden. Subsequently, a study was done by Nelson et al., which demonstrated a definitive association between AMH and live birth weight, irrespective of the treatment and irrespective of the age after treatment. So now the subsequent research after all this has ultimately shown that serum AMH concentration may serve as predictive indicators for live births among women aged more than 34 years. Duration of infertility is an important factor because natural fecundity typically per menstrual cycle is about 20%, and it goes on increasing to about 85% after 12 cycles. Similar pattern is observed in live birth rates when they have undergone IVF treatment, because the underlying cause of this phenomenon lies in the fact that most couples tend to conceive within the initial 12 to 36 months of attempting to conceive. And of course, success rates will diminish in the remaining couples who are less likely to respond to treatment. Prior pregnancy, especially the one achieved through IVF treatment, will enhance the likelihood of success in subsequent IVF treatments, regardless of whether it resulted in a miscarriage or a live birth. This may be attributed to the established quality of the gametes and the demonstrated capability of these women to successfully carry pregnancies to term. There are various research implications. There are various key predictors and models that need to be devised, and machine learning models may allow researchers to explore this. Validation studies are required for a wider application and improved accuracy. We need to include clinical data with some laboratory parameters. Especially in future, we need more complex endocrine imaging and genetic data to be included. We need to go more towards the ensemble modeling, wherein we'll include and compile larger data sets and compile information to improve predictive accuracy. Complex interactions can be studied and predictive accuracy can be improved. Definitely, it has its demerits that there's a steep learning curve and it's expensive to generate. So when we use these models, what we have seen that the patient satisfaction is higher, consumer expectations are met. Before using the tool, 24% of the participants of this Your IVF Success Estimator, which was a prediction tool, was studied. Before using the tool, 24% of the participants were uncertain about their estimated success. But after using it, half of them adjusted their predictions and 26% had their expectations confirmed. So to conclude, 11 predictors are commonly used to estimate the outcome of IVF treatment and the age of the female partner, exercising the maximum influence on the chances of success. Thank you.
Thank you, Ankita. So with this, we'll take, I think, few questions. Everyone can join the IFS. There are so many benefits of the IFS to become the member. You can have so many programs, young empowerment program, counselor program, AI program. So with this, Ankita, you can stop the slide sharing. We'll have few questions. Because today we are, so thank you, Ankita.
Thank you.
Pankaj, first question.
Ankita, it was a very nice study, but there are a lot of lacunae which I see in this study. See, prediction of IVF is a complex subject, and that's why we are not having many studies which are done to predict the IVF outcome, because there are a lot of confounding variables when we try to predict to get the prediction. So that is one limitation, major limitation basically. There was not actually, recently we have been working on looking at the prediction models based on artificial intelligence. So until unless we take into account the larger number of cases through artificial intelligence, we may not be able to find a predictor model, better prediction model. Like in this review, only I think 2 or 3 studies they have used machine learning model. The rest of them, they were pure clinical studies, and that was the major limitation. So until unless we have a very good predictor model based on artificial intelligence, we may not be able to get something new. Like in this study, whatever is concluded, nothing is new as far as the prediction capability of various parameters is concerned. We know that age is important criteria. We know that number of oocyte is important criteria. We know that the quality of oocyte or quality of embryo is a good predictor for IVF. But I feel that there should have been little more emphasis on the cutoff values. Like, I don't know whether they have looked at the cutoff values of AMH, AFC, BMI you told, BMI you told, but AMH and AFC, they have purely clinical parameters. And if we are having, as a clinician, cutoff values where it is going drastically down, okay, on higher side or lower side, that may be little more useful in getting some information from these type of studies.
Exactly. That is more important, especially if the AMH is less than 1. So one more
Yeah,
question.
so until unless we are having a cutoff, we know that if the number of eggs are less, we are going to have a poor outcome. Same time, when we are having a high AMH, we know that patient is at high risk of ovarian hyperstimulation, and the quality of oocyte is very, very poor when we are having a high MH. But what is the cutoff? We are not having any cutoff at present where we can say, yes, this is the cutoff, then we can have a very successful outcome. So that is lacking, and that is what we, as a clinician, we require from such type of studies.
Yeah. So one question from chat box by Dr. Thank you, sir. By
Yeah.
Dr. Sajia Rashid. Level of serum estradiol and oocyte obtained and its outcome in live birth.
Ma'am, it is the same actually, because estradiol and oocytes obtained, everything is so much correlated. Obviously, when and nowadays when freezing is there, so I suppose nowadays the level of estradiol and oocyte obtained should not matter a lot,
Exactly.
because you're giving the honest, you're freezing and then putting it in the next cycle. But yes, when you overstimulate, there's an hyperstimulation. There are reports which say that your oocyte quality is going to get down when the number is more than 20 or 25, because that puts a lot of pressure on the protein machinery of the oocyte, the ribosomes, the the reticulum that starts breaking. And when you retrieve them and you send it to your embryologist, you will say the quality is somewhat compromised and the resulting embryos might not be that great and the number would be less. So obviously, when retrieval is more, when the E2 is more, your quality is going to get down. That probably is going to make a difference to your outcomes, but that would be in the fresh rather than, I would say, in the frozen in the current scenario. Kuldeep sir?
Exactly.
Yeah, estradiol as such is not a very good predictor of outcome uh, on a larger scale. But yes, in that particular cycle, estradiol may be beneficial to predict. But estradiol is not a very good predictor of outcome. Another thing which I thought should have been included, like in such type of studies, because see, the whole concept is changing. So until unless we address these changes in the concept, we may not be able to get much information from such type of study. One is whether the frozen embryo transfer is a better uh, uh, outcome giver cycle. So there should have been something like uh, fresh versus frozen cycle taken into consideration, because that will certainly give a better information for all clinicians. So, so I think there are a lot of limitation in such type of studies. We know they started with 1,000+ studies and ended up only in 43 studies. So that shows there is a lot of limitation. And only age was the common predictor in all studies. Rest of the predictors were not taken into consideration in many studies.
Yeah, so this is purely clinical type of study.
Yeah.
Level of serum estradiol definitely doesn't matter, because even if it's more than 3,000 or 3,500, everyone is going to be freeze nowadays. Next question is age more than 35. What is the range to counsel? So, age, if more than 35. How to counsel if age
Counseling,
35 to 40?
counseling again is multifactorial, because age is just the number. Obviously, when your age is going to be above 35, you expect the apoptosis and the quality to go down, but then that should not be the single factor that should be considered. There are a lot of other factors like what is an AFC, what's your AMH levels, all those things should be considered while discussing this. But one thing is for sure that the live birth rate using the self-X after 35 would be lower than using the same when the patient is lesser than 35. There's no question about that. So age is a bigger predictor, one of the best predictors, I would say.
Oh, again, I think now we are moving to the combination. Uh, uh, like the patient is older, but if we are having a better AFC, we can always counsel the patient that they are having a better chance because now multiple parameters are coming. If the at 36 years, if the AFC is 10, 12, we can always counsel they are still having a good chance. At 36 years, if the AFC is also low, like if their AFC is 3, 4, then certainly we will counsel that yes, there may be problem in the pool. So number of AFC along with age may be a better uh, uh, predictor than separately. So we should take at least 2, 3 predictors which are focusing on the same problem. Then the prediction of outcome will be better.
The same way, ma'am, few days back we were discussing with the gym trainer, what they, when you go to a gym, they would say that your biological age is, for example, 45 or 46, but if you're obese, you're no maintain, they would say that you look like 55 or 60-year-old. The same way when we talk about the live birth rate and we're dealing with a 35-year-old lady, what I have started doing counseling is that your age is 35, but your reproductive age is actually 30, or maybe your reproductive age is 40, your reproductive age 30 years. So this is how the counseling, the girl was asking about the counseling, this is how we counsel with respect obviously to your AMH and other parameters. So you can say that biologically you look 35 or 36, but your ovaries reproductive age looks like 35 or maybe 40 or 45.
Yeah. Any other question? Because this is a subject which is actually very clinical, but at the same time we are not having much information coming out from the literature. So until unless we have something something specific as a predictor, and now there are many parameters which can be just analyzed by AI models, and they can be used in counseling.
So one last question. What is the maximum number of oocyte to be retrieved and of what size, ma'am? Hello?
Yeah, so optimum number again, if you take some studies 15 years back, then that time optimum number was 14 or 15. But now it has reduced. Recent studies have shown that if you are having 9 or 10 oocytes, then you can predict a good outcome. So if it is on higher side, again the outcome may be poor, or if it is on lower side, again outcome may be poor. So optimal number in recent studies has come down to 10 from 14, 15.
Ma'am, you're muted.
Thank you, sir, for your wonderful messages and your take-home points. So I think definitely the study should has been more value type instead of only clinical. And thank you, Ankita, for the nice presentation, and Dr. Sarabjit.
I again invite all the participants to block your date for Fusion 2024. That is in Jaipur, 13th, 14th, and 15th September. And we will be having such type of discussions for all 3 days. So please join and send in your abstract by 15th August. Thank you.
So you all are free to join the Young Turk and present your articles. Clinician, embryologist, everyone can present. Now, I think embryologists should also move forward to have the presentation. So now we can start the quiz.
And another just one more announcement. We are having the fertility Science and Research, that is the official journal of Indian Fertility Society. And we are there to help you. The whole editorial board is ready to help you in getting your article published. If you are having any problem, you can contact any of the editorial team member, Dr. Rupali, Dr. Surveen, or myself. We will try to help you out in submitting your articles for publication. Thank you.
Yeah, thank you, sir. That will be the big help for everyone. Thank you very much. So, Dr. Nikita, can you start the quiz session? Dr. Nikita? Rahul, you can unmute everyone. I think quiz people, they are muted.
Done, ma'am.
Yeah. So today we are having quiz session also along with the journal club. Dr. Nikita, you are here? Dr. Arun, who is here from quiz session? No, everyone is not everyone is muted, I think. Rahul, just check. Rahul?
Yes, ma'am. Yes, ma'am.
Make everyone unmute, na?
Yes, ma'am.
So, Ankita, your certificate will be updated on your group only. So, all who are less than 40 years can join the Young Turk group, and everyone can attend this Young Turk Journal Club. Christine, who is there? Nikita is there?
Differences are different habits and social
वहां पे पप्पा के लिए बैठे थे
नहीं जरा सुन लेते अभी आ रहे सूप लेके आती सूप बने बाद गंगाराम सूप हो गया
Dr. Nikita, you are there from quiz team, or we can wind up the session.
मैम डॉक्टर नितिका ने मीटिंग लीव कर दी है.
No one is here from your side. I think we can wind up then. From
Okay.
quiz, no one is here. So otherwise we'll wind up the session. Okay, okay. In a minute, we'll tell you that we are having quiz session or not. So next will be again on the 2nd of the Friday. So thank you, Dr. Sarvjit, for the joining.
Thank you, ma'am. Thank you very much.
Any other query, you can unmute and ask. All the Young Turk or everyone can join. You can unmute yourself. Definitely age is if you take one predictive, age is the single most predictive, but we have to take everything in accounts. And number of oocyte also doesn't matter. Definitely if the number of oocyte is more, nowadays we are going to have a more success, because if the eggs are more, we are definitely going to have freeze all freeze strategy only.
Yes, exactly.
So what you are doing, Dr. Sarvjit, you are doing all freeze or what you are doing?
Preference would be an all freeze. So in only those cases where the retrieval is less than 10, we actually try to take it as 8 to 12. So if the retrieval of OCC is not M2s, if retrieval is 8 to 12 and your E2 is not more than 2500, your endometrium rest, everything looks good, we'll go with the fresh. And we expect that 1 or 2 extra blasts to be frozen for the cycle if the luxury is there. But if in case things go beyond this, so we'd like to freeze now. Because better oriented cycle, it's a so results obviously are in my center are better when it comes to comparing frozen versus fresh after 2500 E2.
Yeah, definitely. We are getting good result in the fresh
Yes,
transfer
yes,
also.
and
If
yes.
the E2 is less than 3500 and number of eggs are 8 or 10, so
And yes, yes.
definitely. And any serum progesterone value you are taking into account?
Yes, ma'am, less than 1.5 in the stimulated cycle. And if we're doing a FET cycle, then the book says you can go with less than 1.5, but I try to keep it even less than 0.5. So that there's a block, generally the clinical block that comes with an experience. So I do not want even a single iota of progesterone before I start my progesterone FET. So lesser means should be less than 0.5 basically. In stimulated cycle 1.5, book says that up to 2.5 you can do, but I don't do. Because there's always an option of freezing, ma'am. So it's a self-sponsored cycle. Freezing nowadays is easy, is well documented. Every
Good
embryologist is
result
now
and
well
good
versed.
retrieval,
Good
definitely.
retrieval, good results. So whenever you feel there is a confusion, so why not to go for frozen embryo transfer?
Yeah, so if single reading, we take it 1.5, but
Yes.
otherwise in poor responder, we take the cut of 1.25, and in hyper responder, we can wait up to even 1.75.
Can be, yes, yes.
Actually, we take ratio of the estrogen and progesterone.
Okay.
And any progesterone you do on the day of transfer?
No, we don't do it, ma'am, because we already
Dr. Nikita, we are waiting. Are you going to do quiz or not? Okay. Okay. Pardon?
So we already are actually using, ma'am, 2 routes of progesterones with 400 vaginal twice and 50 aqua progesterone. So doing progesterone doesn't make a difference actually because we already are supplementing extra progesterone. But yes, if you're using lesser than that, if you find that your progesterone cutoff level is lesser in your luteal phase, you can increase or postpone it to the next. We are not doing it because we are already supplementing them with the full dose.
And they say we do the progesterone level on the day of transfer, and if it's less than 10, then we cancel the cycle.
So using 2 progesterone routes or 3 progesterone routes?
2,
2.
not more than 2, 1 or 2. Yeah.
Okay.
So thank you very much. Thank you, Dr. Sarvjit, and thank you all the young Turk and Ankita. So with this, we wind up and we wait for the next session.
Thank you. Thank you.
And everyone is requested to become the member who is still not member. We are having so many program, Young Turk program, counseling program, nurses training program, quiz sessions, various sessions are there. So all still not member, become the member. Anything else you want to say, Dr. Sarvjit?
I think, ma'am, that's a wonderful actually initiative, and you people are doing a great job. Young people actually needs a lot of motivation. Okay, so this is one kind where they can come and they can interact with the learned faculties, get trained, and would do good to their the future also.
Thank you.
Thank you, ma'am. Thank you very much.
Thanks.
Okay.